Um, what if the very medication that makes a patient feel instantly better is, secretly guaranteeing that they will never actually recover? Welcome to this deep dive.
Yeah, it's a pretty staggering clinical paradox, but it is exactly what we're dealing with today.
Right. So I want you to imagine for a second that you're working in an emergency department and a patient is brought in with a severe compound fracture of the femur. I mean, the bone is exposed, the pain is entirely unimaginable, and their distress is just off the charts,
Naturally.
right? So as a clinician, your first instinct is to help. So you give them a massive, overwhelming dose of intravenous painkillers, and they immediately stop screaming, their heart rate drops, they look up at you and literally thank you for saving them.
Which feels great in the moment.
Exactly. But then, because they can no longer feel the pain, you just tell them to go outside and run a marathon.
Yeah, which is, I mean, we would universally call that malpractice.
100% malpractice. The structural damage to that leg is compounding with every single step, even if the pain alarm is temporarily silenced by the medication. Yet when we talk about treating the fear circuitry of the brain in traumatized patients, this is exactly the paradigm we have accepted for decades.
It really is. We're handing out the psychiatric equivalent of heavy painkillers for a broken foundation, and then we're, wondering why the house keeps collapsing.
So if you are stepping into this space with us today, you are likely a clinician, a prescriber, or, a dedicated student of psychopharmacology. We know that in medicine, we are driven by this profound instinct to alleviate human suffering. But today, our mission is to look at a clinical trap that has defined and in many ways completely derailed trauma treatment.
And we are talking specifically about PTSD pharmacology lesson 6, what to avoid, meaning the widespread use of benzodiazepines. It's a practice that feels right in the room but looks absolutely disastrous in the long-term data.
Right. We need to understand exactly why these medications harm PTSD outcomes.
Mm.
We aren't just going to give you like a list of administrative rules or a wag of the finger.
No, we need to go deeper than that.
Exactly. We are going to unpack the underlying neurobiology, the receptor level mechanisms, and the clinical psychology of this trap. And most importantly, we want to equip you with the actual tools to manage your highly distressed patients without relying on these drugs.
And to do that, we're drawing heavily from some of the most rigorous evidence-based texts in the entire field. We'll be synthesizing deep pharmacological insights from Stahl's Essential Psychopharmacology. We're also looking at the clinical tapering and management frameworks from the Maudsley prescribing guidelines in psychiatry.
Which is basically the Bible for this stuff.
Oh, absolutely. And we'll be grounding our treatment decisions in the highly specific psychopharmacology algorithms developed by the Harvard South Shore Psychiatry Residency Program.
So consider this a masterclass. We are talking peer-to-peer. No fluff, just the heavy-hitting science and the real-world prescribing decisions you face every day. So let's just jump right in. To understand how we ended up in this trap, we really have to put ourselves in the shoes of the prescriber historically. Because for a very long time, benzodiazepines weren't just common for PTSD. They were the absolute standard reflex.
Yeah, they were the go-to.
How did we get to a place where this was the default tool?
Well, you really have to empathize with the clinician sitting across from a patient who is in profound, visible distress. When someone with acute PTSD comes into your office, I mean, you aren't looking at a theoretical chart. You are looking at a human being who might be experiencing a severe panic attack right in front of you.
Right, they're shaking, sweating.
Exactly. They're dealing with crippling hyperarousal or describing this overwhelming, inescapable terror. Their sympathetic nervous system is entirely hijacked. And the clinical instinct, the deeply human instinct, is to put out that fire immediately. You want to offer rapid anxiety relief and profound sedation just to give them a desperately needed break from their own nervous system.
And let's be intellectually honest here, right? In the short term, benzodiazepines do exactly that. They are incredibly, almost miraculously effective at shutting down acute panic.
They work very well for what they do in that exact moment.
But you're essentially treating a house fire by pulling the pin on a massive industrial fire extinguisher and spraying down the living room every single day. Sure, the flames stop immediately, the smoke clears for a few hours.
But the foam covers everything.
Right. The thick foam covers everything, the structural fire damage remains entirely untouched, and you can never actually get a construction crew in to fix the foundation. You're just managing the flames, not rebuilding the house.
That visual captures the clinical reality perfectly. Because the immediate gratification of seeing a patient's distress drop from, like, a 10 out of 10 down to a 2, is an incredibly powerful psychological reinforcer for the prescriber.
Oh, totally. You feel like a hero.
Right. The patient is profoundly grateful, you feel like a highly effective healer, and the acute crisis of that 15-minute med check is averted. But that shared gratification completely masks the long-term structural stall happening in the brain. We essentially traded acute sedation for chronic, deeply entrenched pathology.
So let's look at the specific tools, the fire extinguishers, if you will, that have been historically misused this way. Let's break down the big four common benzodiazepines you will inevitably see on patient charts or, legacy prescriptions.
We need to understand their onset, their duration, and their potency.
Because those pharmacokinetic properties dictate exactly how the trap snaps shut. So let's start with arguably the most infamous, alprazolam, better known by its brand name, Xanax.
Okay, so alprazolam, or Xanax, is a highly popular, fast-acting benzodiazepine with a very short half-life. It is incredibly potent at the receptor level, but because of that very short half-life, the actual clinical duration of action, the amount of time the patient actually feels relief, is often much shorter than its plasma half-life would suggest.
So it burns off fast.
Very fast. The clinical effect wears off rapidly, which means patients often find themselves having to dose it multiple times a day just to maintain baseline.
Take a second and look at your own charts right now as you're listening.
Mhm.
Are you seeing this? Because what you're describing with alprazolam or Xanax sounds less like a steady treatment and more like a roller coaster.
A roller coaster is exactly what it is. It creates these intense, violent peaks and valleys in the patient's bloodstream, and consequently in their brain chemistry. They take the pill and get a rapid peak of profound relief, followed hours later by a steep, sudden valley.
And that valley is where the trouble starts.
Exactly. That sudden drop in serum levels triggers severe inner dose anxiety. The brain literally starts panicking, waiting for the next dose. Furthermore, because of this rapid clearance from the body, the risk of seizures upon abrupt withdrawal is exceptionally high.
Wow.
If a patient suddenly stops taking alprazolam or Xanax, particularly within the first 3 to 5 days, they are in acute neurological danger, especially if they have a history of head injuries or concurrent substance withdrawal.
Okay. Next up is lorazepam, brand name Ativan. Now this one has a fascinating, if somewhat dark history regarding how it became so ubiquitous, especially in primary care.
It does. Lorazepam, or Ativan, has a fast onset and a medium duration of action. Clinically, it's heavily relied upon in acute settings like emergency departments or inpatient units for rapid chemical restraint or acute panic.
Right.
But its history is really tied to aggressive direct-to-consumer marketing in the late 1970s and 80s. It was marketed to the public and to doctors with slogans essentially promising the Ativan experience as a cure for the stress of modern life.
The Ativan experience. That is, wow.
Yeah. That historical marketing really entrenched it in outpatient medicine as a catch-all, ubiquitous solution for any kind of anxiety or trauma presentation.
Okay, then we have clonazepam, brand name Klonopin. Now, I want to pause here because I hear colleagues all the time say that clonazepam is the safe benzodiazepine, or at least the safer one for long-term use.
Sure.
Why do we collectively think that, and is it actually true?
It's an incredibly common clinical misconception. So clonazepam, or Klonopin, is a longer-acting agent. Because it has a longer half-life, it doesn't create those rapid, violent peaks and valleys that we see with alprazolam or Xanax.
So it's a smoother ride.
It's a smoother ride.
Mhm.
And because the interdose rebound anxiety is less obvious, clinicians often mistakenly believe it is inherently less addictive or easier to manage long-term. But here's a reality. While it might not trigger the immediate frantic craving between doses, the physiological dependence it creates at the receptor level is just as profound.
It's just hiding it better.
Exactly. In fact, it can be more insidious because patients can remain on clonazepam or Klonopin for decades under the false assumption of safety, all while their underlying trauma remains completely unaddressed.
And finally, the classic. Diazepam, brand name Valium.
Diazepam, or Valium, is characterized by a very fast onset but an incredibly long half-life. The parent drug is active, but it also breaks down into active metabolites, like desmethyldiazepam, which linger in the system for a very long time,
Like, how long?
sometimes over 100 hours. Because of this, it essentially self-tapers to a degree. The blood levels drop very, very slowly. While it's much less commonly initiated for new PTSD patients today, you will absolutely still see legacy patients in your practice who were put on it 20 years ago and have never been taken off.
So we have the roller coaster of alprazolam, or Xanax, the acute reflex of lorazepam, or Ativan, the false safety of clonazepam, or Klonopin, and the legacy persistence of diazepam or Valium.
Yeah.
To understand why all four of these are contraindicated in trauma, we can't just look at the clinical symptoms. We have to go down to the receptor level.
Right.
Let's look at the mechanism of the trap. What are these drugs actually doing in the brain?
At the neurobiological level, as detailed in Stahl's Essential Psychopharmacology, benzodiazepines act as GABA positive allosteric modulators, or GABA PAMs. Let's break that down carefully.
Yeah, let's unpack that.
GABA gamma aminobutyric acid is the primary inhibitory neurotransmitter in the central nervous system. It is the brain's natural braking system. Now, benzodiazepines do not act directly as GABA. They don't press the brake pedal themselves.
Right.
Instead, they bind to a specific separate site on the GABA A receptor and allosteric site. When they bind there, they change the physical conformation of the receptor, making it wildly more sensitive to the natural GABA that is already floating around in the synapse.
So returning to a car analogy, it's exactly like installing a highly sensitive power steering system on those brakes. You barely tap the pedal and the car screeches to a violent halt.
Exactly. When the receptor becomes that sensitive, it dramatically increases the frequency with which the ion channel opens. This allows a massive influx of negatively charged chloride ions to rush into the neuron.
And what does that do?
Well, when you flood a neuron with negative ions, you hypopolarize it. You push the internal electrical charge so far into the negative that it becomes incredibly difficult, almost impossible, for that neuron to reach the threshold needed to fire an action potential. The net result across the brain is widespread central nervous system inhibition and profound, sweeping sedation.
Okay, I have to push back here. I have to play devil's advocate because if I'm a clinician listening to this, I'm thinking, wait a minute. If PTSD is fundamentally a state of hyperarousal, if the patient's sympathetic nervous system is stuck in overdrive, their amygdala is flashing red and they're constantly scanning for threats, isn't hyperpolarizing the brain exactly what we want? If the brain is overactive, why isn't profound CNS inhibition the absolutely perfect pharmacological tool for the job?
It is a brilliant question, and it is the exact logical trap that kept the entire psychiatric field prescribing these drugs for decades. It seems entirely logical on the surface, but this brings us to the core tension of trauma pharmacology.
Which is?
The tension between short-term sedative effects and long-term synaptic impairment. When you globally inhibit the central nervous system by flooding neurons with chloride ions, you are indeed shutting down the acute fear response. The amygdala goes quiet.
Right.
But you are also shutting down the brain's ability to form new neural pathways. Neuroplasticity, the fundamental mechanism of learning, memory, and recovery, requires neurons to fire, to communicate across synapses, and to wire together in new configurations.
Oh, wow, okay.
By forcing the brain into a state of hyperpolarized silence, you produce immediate anxiolysis, yes, but you completely paralyze the neurobiology of recovery. You freeze the brain in its traumatized state.
Which brings us to the absolute core of today's deep dive.
Yeah.
We aren't just saying that benzodiazepines are ineffective for PTSD. We are saying they're an active biological barrier to getting better. Let's unpack the exact mechanisms of why they harm outcomes. Let's start with the concept of fear extinction, because this is like the holy grail of trauma recovery.
It really is.
What is fear extinction and how do benzodiazepines ruin it?
Recovery from trauma relies on a very specific type of emotional learning called fear extinction. Let's use a clinical example. Imagine a combat veteran who associates the sound of a low-flying helicopter with a horrific, life-threatening event in a war zone.
Okay.
The unconditioned stimulus, the trauma, was paired with the conditioned stimulus, the sound. Now, years later, their amygdala fires a massive, overwhelming fear response every time they hear a news helicopter in their civilian hometown.
Right, a classic PTSD trigger.
Exactly. Now, fear extinction is the neurobiological process where the brain learns that the helicopter in their hometown is safe. To do this, the ventromedial prefrontal cortex, the VMPFC, has to build a new inhibitory neural pathway down to the amygdala. It essentially has to send a signal saying, stand down, the context has changed, we are safe now.
But building that new pathway, laying down that new safe track, requires the pyramidal neurons in the prefrontal cortex to actually fire action potentials.
Precisely. It requires robust, active neural transmission. If the patient is taking a GABA undulator like alprazolam or Xanax or lorazepam or Ativan, those pyramidal neurons in the prefrontal cortex are hyperpolarized. They are flooded with chloride ions. They cannot fire.
So the message literally never gets sent.
The necessary neural signaling is chemically blunted. Therefore, the brain is pharmacologically prevented from learning that the stimulus is safe. The trauma memory remains locked in its original, terrifying, unextinguished state because the biological mechanism required to update that memory fear extinction has been disabled by the medication.
So think about the practical implications of this for psychotherapy. When a patient goes into an evidence-based trauma therapy, say cognitive processing therapy or CPT or prolonged exposure, PE, what actually happens if they take a benzodiazepine right before the session to, calm their nerves?
The therapy session is rendered virtually useless. Both CPT and PE require the patient to actively engage with their traumatic memories and the intense, distressing emotions associated with them. In prolonged exposure, they literally have to vividly recount the trauma to habituate to the fear.
They have to feel the fear to process it.
They have to feel the fear in a safe environment for the brain to process it. Benzodiazepines cause profound emotional blunting. They artificially disconnect the patient from their affective experience.
Yeah.
If you cannot access the emotion, you cannot process the trauma.
It's like you are essentially showing up to an intense physical therapy appointment after taking a massive dose of heavy muscle relaxants. The therapist can move your limbs around, but you can't actually do the structural work to rebuild the muscle.
That's a perfect way to put it. You can't do the work because the biological system is offline.
And this feeds right into the deepest psychological trap of PTSD, which is avoidance. I mean, PTSD is, at its core, a disorder of behavioral and emotional avoidance. People avoid crowds, they avoid driving, they avoid loud noises, and they avoid their own internal memories and feelings.
Exactly. And taking a pill to immediately escape a negative internal affect is the ultimate, most efficient avoidance behavior possible.
Wow, yeah.
When a patient feels a spike of anxiety, feels that terror rising, and immediately takes a lorazepam or Ativan or a clonazepam or Klonopin, they are reinforcing a deeply pathological psychological loop. They are teaching their own brain that their anxiety is intolerable, that it is dangerous, and that the only possible way to survive it is to chemically escape it.
The medication becomes a powerful reinforcer of the very avoidance pathology we are trying to treat.
Exactly. They never learn that a panic attack will eventually peak and subside on its own.
And we really want to stress that this isn't just an elegant neurobiological theory. We have to look at the hard clinical data. If you consult the Harvard South Shore psychopharmacology algorithms, which are meticulously evidence-based, they explicitly note that in a rigorously designed placebo-controlled trial, alprazolam, or Xanax, showed absolutely zero efficacy for the core symptoms of PTSD.
Zero.
It might put the patient to sleep, or it might arrest an acute panic attack in the moment, but it does absolutely nothing to treat the underlying disorder. In fact, as we've just unpacked, it makes the long-term prognosis much worse.
It does. And while the brain is failing to heal the trauma due to blocked fear extinction, the rest of the body isn't just sitting idle. The central nervous system is actively adapting to the constant presence of the drug, which takes a massive physiological toll. This brings us to the harsh realities of dependence, tolerance, and withdrawal.
Let's talk about tolerance first. From a purely pharmacological standpoint, how fast does tolerance to a benzodiazepine actually happen?
Frighteningly fast, particularly for the sedative and anxiolytic effects. Tolerance can develop within just 2 to 4 weeks of regular daily use.
Just weeks.
Yes. Remember those GABA-A receptors we talked about? The brain is a highly adaptive system. It recognizes that it is being artificially hyperpolarized all the time. To counteract this, it downregulates the receptors. It either reduces the total number of GABA receptors on the cell surface, or it changes their conformation so they are less sensitive to the drug.
Suddenly, that 0.5 milligram dose of alprazolam or Xanax that used to completely calm the patient down does almost nothing.
Right.
So the patient comes back to the clinic, says it stopped working, and the prescriber escalates the dose.
Inevitably. The prescriber increases the dose to chase that initial profound relief, and a very dangerous escalating cycle begins. Because the half-lives of these drugs dictate how often the brain experiences a drop in the chemical, patients become physically dependent very quickly. The brain literally forgets how to break on its own.
And when they miss a dose, or when a well-meaning clinician tries to abruptly stop the medication, the withdrawal is brutal. I mean, we are talking about severe rebound anxiety, intractable insomnia, profound physical agitation, tremors, and diaphoresis.
It's miserable.
And in extreme cases, especially with short-acting agents like alprazolam or Xanax, discontinued abruptly, there's a very real life-threatening risk of grand mal seizures. But I want to ask about the subjective experience of the patient here. Why are PTSD patients specifically so incredibly vulnerable psychologically to this withdrawal syndrome?
This is a tragic synergy, and it's vital for prescribers to understand it. Think back to our fear extinction mechanism. We established that benzodiazepines block the processing of trauma. So imagine a patient takes clonazepam or Klonopin daily for 2 years.
Okay.
During those 2 entire years, their core PTSD has not healed, it has just been chemically muted. When they, or their doctor, try to stop the medication, they don't just experience the standard physiological rebound anxiety of GABA withdrawal, which is terrible on its own. They experience that physiological rebound multiplied by the sudden, brutal unmasking of a completely untreated, unhealed, raw trauma disorder. The fire alarm system comes violently back online, and the fire in the house is still raging just as hot as it was 2 years ago.
That is devastating. So what the patient subjectively perceives as, oh my God, my PTSD is coming back, my disease is getting worse, is actually a horrific combination of GABA withdrawal and the original untouched trauma hitting them all at once. No wonder they run back to the clinic begging to go back on the medication. It's a living nightmare.
It really is.
And honestly, the day-to-day existence on these drugs isn't much better, even before they try to stop or taper. Let's look at the cognitive and functional impairment that happens while they're actively taking them.
The list of daily functional impairments is extensive and deeply impacts quality of life. We see profound anterograde amnesia, which is the inability to form new memories efficiently while under the influence of the drug. We see reduced attention span, impaired cognitive processing speed, delayed reaction times, and chronic pervasive daytime grogginess.
If we tie that cognitive impairment back to therapy, if a patient literally cannot form new memories efficiently due to anterograde amnesia, how on earth are they supposed to retain the complex cognitive reframing insights they gain in a 60-minute cognitive processing therapy session?
They simply can't. The insights slip right through their grasp. They might have a profound breakthrough in the therapist's office, but by Tuesday, the memory of that cognitive shift is gone, washed away by the medication. But beyond memory, there is another functional impairment that often catches well-meaning clinicians completely off guard, and that is the risk of paradoxical reactions.
Right, I really want to dig into this because it sounds completely contradictory. You're telling me that a drug fundamentally designed to calm people down, a profound central nervous system depressant, can actually cause aggression, rage, and acute agitation. Like, how is that pharmacologically possible?
It seems completely counterintuitive, but paradoxical agitation and behavioral disinhibition are very real, very dangerous risks, particularly with drugs like lorazepam or Ativan and alprazolam or Xanax.
Who does this happen to?
It happens most often in specific vulnerable populations. We see it in children, we see it in the elderly, and specifically in the trauma space, we see it in patients with a history of traumatic brain injury, or TBI, which is highly comorbid in military and veteran populations.
Okay, what's the mechanism?
The mechanism is thought to be very similar to the mechanism of alcohol disinhibition. By depressing the higher cortical areas of the brain, the prefrontal cortex, which normally exerts top-down logical control over our impulses and aggression, the lower, more primitive emotional centers like the amygdala are essentially unleashed. You depress the system that controls the rage, the brake pedal breaks.
So you have a veteran with a mild PBI and PTSD who is agitated. You prescribe a benzodiazepine to calm them down. And instead of going to sleep, you get acute combativeness, rage, and potentially violent disinhibition. That is a terrifying clinical scenario for everyone involved.
Truly terrifying.
And speaking of terrifying clinical scenarios, we have to look at what I call the PTSD vulnerability multiplier, the intersection of trauma and comorbid substance use disorders.
This is the critical juncture where prescribing these medications crosses the line from being merely counterproductive to being actively lethally dangerous. Populations suffering from PTSD have a significantly higher baseline risk of developing comorbid substance use disorders, particularly with alcohol and opioids. They are desperately attempting to self-medicate their hyperarousal, their physical pain, and their emotional numbness.
And if you introduce a prescribed benzodiazepine into that mix, you are inviting an absolute disaster.
You are creating a lethal cocktail.
Well,
The FDA has issued a black box warning, which is their strictest, most severe level of caution, specifically regarding the co-prescription of benzodiazepines and opioid medications. When you combine a GABA modulator like diazepam or Valium or clonazepam or Klonopin with an opioid or with heavy alcohol use, the synergistic depression of the central nervous system is exponential, not just additive.
wow, exponential?
Yes, you are looking at a profound compounding risk of extreme sedation, respiratory depression, coma, and fatal overdose. The drive to breathe is literally shut off at the brainstem.
So for you listening, if you're treating PTSD in a vacuum, If you are reaching for your prescription pad to write for lorazepam or Ativan without doing a rigorous, honest, and continuous assessment of the patient's alcohol or opioid use, you are operating dangerously. Prescribing CNS depressants to this highly vulnerable population is walking a tightrope without a net.
Which is exactly why the highest levels of clinical consensus globally have ruled firmly against it. Let's look at the verdict from the evidence and the major clinical guidelines.
Yes, let's look at the consensus. The VA and DoD clinical practice guidelines in the United States, the NICE guidelines in the UK, which are famously stringent, and the Harvard South Shore algorithms all arrived at the exact same unequivocal conclusion. They strongly, explicitly recommend against the use of benzodiazepines for the treatment of PTSD.
The clinical evidence behind those guidelines is massive. Research consistently demonstrates that PTSD patients treated with benzodiazepines have worse long-term outcomes than those who receive no medication at all. Let me repeat that. They do worse than patients who receive a placebo.
That is just wild to think about.
And the long-term data brings even more alarming risks to light as patients age. There is a very concerning meta-analysis referenced in the Maudsley guidelines showing an odds ratio of 1.4 for the development of dementia with long-term benzodiazepine use. We aren't just talking about temporary brain fog anymore. We are talking about a significantly increased risk of permanent, irreversible cognitive decline.
Okay, let's summarize the rap sheet so far. We have a drug class that actively blocks trauma therapy, worsens the underlying fear disorder, carries severe addiction and brutal withdrawal risks, causes paradoxical rage in TBI patients, can literally kill you via respiratory depression if mixed with alcohol, and significantly increases your risk of dementia.
That's quite the list.
Which brings us to a really uncomfortable question about the psychology of prescribing. If the data is this bad, why do clinicians keep doing this? Why is there such a massive, glaring contrast between standard clinical practice out in the community, where these drugs are still handed out like candy, and the strict evidence-based guidelines?
It fundamentally comes down to the psychology of prescribing and the intense interpersonal pressure of the clinical encounter. As a clinician, you are sitting alone in a room with a human being who is suffering deeply right in front of you. You went into medicine to help people. Benzodiazepines feel incredibly helpful in the immediate 15-minute short-term window.
Yeah, you see the result right then and there.
You write the script for lorazepam or Ativan, the patient takes it, their visible distress drops away, they sigh in relief, and they view you as a savior. You have solved the immediate problem for the patient, and you have solved the immediate anxiety for yourself as the provider. But it is a clinical trap rooted entirely in short-term thinking.
Again, I want to push back, because I really want to honor the difficulty of that moment in the clinic. If I have a single mother in my office who hasn't slept more than 2 hours a night in a week because of severe panic attacks, and she is at risk of losing her job, tell me to worry about long-term synaptic neuroplasticity and fear extinction pathways feels like an academic luxury. It feels almost cruel to withhold the one chemical that will let her rest tonight. How do you practically, ethically justify denying that immediate relief in the room?
It is the hardest part of the job, without question. But true clinical compassion requires us to look past the next 24 hours. If you give her that script, you might save her job this week. But you are initiating a cascade that could cost her her cognitive function, her ability to process her trauma, and potentially her life if she mixes it with a glass of wine a year from now. True compassion is refusing to enable a destructive cycle. It is having the courage to tolerate the patient's immediate distress and your own discomfort in order to facilitate long-term structural healing. And that requires having incredibly tough, honest conversations.
So let's get into the real-world application. We need to give you, the listener, the actual conversational frameworks and tools to navigate these tough interactions. Let's role-play a few scenarios. Scenario 1. The requesting patient. You have a new patient who comes in actively demanding lorazepam or Ativan. They say, look, doc, my old psychiatrist gave this to me. I've tried breathing exercises, I've tried therapy, and Ativan is the only thing that actually works for my panic attacks. Just give me the script. How do you handle that without alienating them or throwing their previous doctor under the bus?
This requires a delicate blend of deep clinical compassion and completely firm boundaries. First, you must validate their suffering. You say, I hear how incredibly painful these panic attacks are, and I completely understand why you want relief. It makes perfect sense that you want the medication that makes the pain stop.
Right, you're not dismissing their pain.
Exactly. Then you pivot to psychoeducation without being condescending or defensive. You might say, my goal isn't just to put a band-aid on your symptoms. My goal is to help your brain actually heal from the trauma. The medical science has evolved, and the evidence now shows us that while Ativan makes you feel better for a few hours, it chemically prevents your brain from processing the trauma in the long run. It's like taking a heavy painkiller for a broken bone and never letting me put a cast on it. I want to work with you on treatments that actually fix the underlying alarm system rather than just unplugging it temporarily.
I love that approach. You align with their fundamental desire to feel better, but you rigorously redefine what better actually means in a clinical context.
Okay.
Scenario 2, the dependent patient. You inherit a patient who's been taking daily clonazepam or Klonopin for 10 years. It's a legacy prescription. They aren't abusing it, they take it exactly as prescribed, but they're terrified of stopping. What's the framework here?
The prime directive here is do no harm. You never, ever abruptly discontinue a legacy prescription just to prove a point or strictly adhere to a guideline. That is dangerous. You start by acknowledging their fear. You say, you've been on this medication a long time, it has been a crutch for you, and I know the idea of changing it is incredibly scary.
So you name the fear right away.
Right. Then you plant the seed for the future without threatening their immediate stability. The science has evolved a lot in the last 10 years, and we now know that this medication might be keeping your trauma stuck in place or causing issues with your memory as you age. We are absolutely not going to stop it today. But over the next few months, I want us to build a collaborative plan together to very, very slowly reduce it while we simultaneously add in therapies and safer medications that actually support your recovery. You make it a shared long-term project, not an immediate deprivation.
That collaborative pacing piece is key. You aren't ripping the rug out from under them. You are building a new floor first. And finally, scenario 3, PRN versus daily dosing. I see a lot of well-meaning clinicians who think, well, I know benzos are bad long-term, so I'll just give them a very small prescription of alprazolam or Xanax, maybe 10 pills a month, to use strictly as needed, or PRN for severe panic. That's safer than taking it every day, right?
Paradoxically, from a psychological standpoint, as needed or PRN dosing can actually be much worse for the core pathology of PTSD.
Really? Because it reinforces the avoidance loop we talked about.
Exactly. When a patient is instructed to take a pill only when they feel a spike of severe panic, you are creating a direct, intensely powerful behavioral reinforcement loop. The cycle is, I feel terrible, I take a pill, I feel better. Operant conditioning takes over. They learn on a primal level that their own anxiety is an absolute emergency that requires immediate chemical rescue.
Oh, wow. So you're accidentally training them to fear their own anxiety even more?
Right. They never learn the crucial psychological lesson that they can tolerate distress, and that anxiety, even severe panic, will eventually peak and subside entirely on its own. If a benzodiazepine absolutely must be used temporarily, perhaps as a very brief 2-week bridge while waiting for an SSRI to kick in, which is still highly debated, scheduled dosing is actually preferred psychologically.
Yeah.
Giving it at set times, regardless of how they feel, disconnects the physical act of taking the pill from the subjective experience of anxiety.
That is such a counterintuitive but absolutely brilliant clinical pearl. Disconnect the pill from the panic. Okay, so let's say we've had the tough conversation, the patient is on board, and they have agreed to come off their legacy medication. Now we have to talk about the physical mechanics of stopping. We can't just tell them to throw the bottle away. The neurobiology we just discussed, those downregulated GABA receptors, means their brain is physically incapable of breaking on its own. How do we safely step down the dosage without triggering the exact seizures we're trying to avoid?
We cannot overstate the physiological danger of abrupt discontinuation. We've mentioned the seizures, the psychosis, the rebound anxiety. The Maudsley prescribing guidelines provide excellent, highly detailed principles for gradual dose reduction. The core philosophy is the stabilize-reduce method.
So what does the math of that actually look like? How slow are we talking?
Very, very slow. You drop the dose by a microscopic increment, and then you hold that dose until the patient's body stabilizes and the withdrawal symptoms entirely subside. Only then do you make the next drop. For example, if you have a patient on a high dose, you might drop the dose by the equivalent of 1 to 2 milligrams of diazepam every 2 to 4 weeks, strictly provided they tolerate it. And notice I said the equivalent of diazepam.
Right, you mentioned transitioning them. Why do clinicians often switch a patient from something like alprazolam or Xanax to diazepam or Valium just to conduct a taper? Why not just cut the Xanax pill in half?
It's all about smoothing out the pharmacokinetic curve. Alprazolam, or Xanax, has a short half-life. If you try to taper it directly, even with small cuts, the blood levels drop too fast between doses, causing severe microwithdrawals and intense suffering. Diazepam or Valium has a massive half-life.
So it softens the landing.
Exactly. By using an equivalence chart saying zero point 0.5 milligrams of alprazolam roughly equals 10 milligrams of diazepam, and carefully cross-tapering the patient to diazepam, you create a much smoother, gentler decline of the drug in their bloodstream. The active metabolites linger, mitigating the shock to the central nervous system. It acts as a pharmacological parachute.
So as they're tapering, even with the parachute, they're going to feel worse before they feel better. The anxiety is going to spike. How do you, as the clinician sitting across from them, differentiate between a true PTSD relapse, meaning their underlying disease is actually getting worse, and just the standard expected benzodiazepine withdrawal syndrome?
This is one of the most critical clinical judgments you have to make. The timeline is your best clue. Withdrawal symptoms typically peak within a few days to a week after a specific dose reduction, depending on the drug's half-life, and then they will gradually, reliably improve as the body stabilizes over the next few weeks. If the severe anxiety, insomnia, and agitation follow this predictable wave spiking after a cut and then settling back down, it is almost certainly withdrawal. You reassure the patient, hold the dose steady, and wait.
But what if the symptoms don't settle? What if they just continue to climb and stay severe for months without resolving?
Then you are likely looking at the unmasking of the underlying PTSD. The withdrawal has revealed the depth of the original trauma. In that case, you don't necessarily go back up on the benzo. Instead, you need to aggressively optimize their alternative evidence-based treatments. You need to treat the trauma that was hiding beneath the pharmacological blanket.
Which brings us perfectly to the most important question for the prescriber. We can't just take away the fire extinguisher and leave them sitting in a burning house. What is in our evidence-based clinical toolkit? Let's build a new regimen from the ground up. What is the foundation?
The foundation of pharmacological treatment for PTSD remains the serotonin reuptake inhibitors, or SSRIs. Specifically, the guidelines point to sertraline, brand name Zoloft, and paroxetine, brand name Paxil. These are the only two medications currently strictly FDA approved for PTSD.
And crucially, why do we use these instead of benzos? What are they doing differently at the biological level?
This is the critical distinction. Unlike benzodiazepines, which just indiscriminately suppress the CNS and paralyze learning, SSRIs actually target the core symptoms of the disorder, the intrusive thoughts, the hyperarousal, the emotional numbing, while supporting neuroplasticity. Chronic administration of SSRIs has been shown to increase brain-derived neurotrophic factor, or BDNF.
BDNF, which is...
BDNF is essentially fertilizer for the brain. It helps neurons grow new dendritic spines, form new connections, and facilitates that crucial fear extinction process we talked about. SSRIs help the patient's brain engage in therapy rather than chemically blunting them from it.
We also look at the serotonin norepinephrine reuptake inhibitors, the SNRIs, like venlafaxine, brand name Effexor. This provides broad symptom coverage by bringing norepinephrine regulation into the mix, which can be highly effective for hyperarousal. But let's talk about the specific symptom that tortures so many PTSD patients: sleep. If a patient hasn't slept in a week, and we can't give them a hypnotic benzodiazepine or a Z drug, what do we do about the trauma nightmares and the nocturnal hyperarousal?
This is where we look at the alpha-1 antagonist prazosin, brand name Minipress. This is a fascinating use of pharmacology. Prazosin was originally developed as a blood pressure medication, but it is highly lipophilic, meaning it crosses the blood-brain barrier very effectively. Once in the brain, it blocks norepinephrine at the alpha-1 receptors.
Let's dig into the mechanism of those nightmares. Why does blocking norepinephrine stop them?
During normal REM sleep, the part of the brain that produces norepinephrine, the locus coeruleus, essentially shuts down. It goes quiet, allowing you to dream without physically acting out or panicking. But in PTSD, the locus coeruleus is dysregulated. It stays hyperactive during REM sleep, flooding the brain with norepinephrine. This adrenaline surge turns regular dreams into vivid, terrifying combat or trauma nightmares, causing the patient to wake up thrashing and soaked in sweat. Prazosin blocks those alpha-1 receptors, essentially shielding the brain from the adrenaline surge and allowing normal REM sleep architecture to return without the terror.
That is incredible. You are restoring the architecture of sleep, not just sedating the patient into unconsciousness. But how to dose it safely, since it is a blood pressure drug?
Proper titration is everything. While some recent large trials have shown mixed results, the Harvard algorithms and many VA clinicians still find it highly effective when used correctly. Because it lowers blood pressure, you must start at a very low dose, typically just 1 milligram at bedtime, or QHS. This is strictly to avoid orthostatic hypertension, which is the sudden, dangerous drop in blood pressure when a patient stands up out of bed, causing them to faint and potentially injure themselves. You start at 1 milligram, and you titrate it up very slowly over weeks based on symptom response and their blood pressure tolerance, sometimes going up to 10 milligrams or 15 milligrams in severe cases.
What about other symptom-based alternatives? So let's say a patient has severe insomnia, they just can't fall asleep, but they don't necessarily have the vivid combat nightmares that require prazosin. What else can we use?
Trazodone, brand name Deserol, is a highly effective non-habit-forming option. It's an older antidepressant that, at lower doses, acts as a potent histamine and serotonin antagonist, providing excellent sedation and improving sleep architecture without the risk of dependence. For the somatic, physical sensations of anxiety during the day, the racing heart, the tight chest hydroxyzine, brand name Vistarol, can be very useful. It's an antihistamine that provides calming, mild, sedative effects without any of the GABA-A risks. And for a generalized anxiety overlay, Buspirone, brand name Buspar, is an excellent choice. It's a 5-HT1A partial agonist. It does take time to build up in the system, usually 2 to 4 weeks, unlike a benzo, but it provides foundational anxiety relief without causing cognitive impairment, without blocking fear extinction, and with zero risk of addiction.
Look at that toolkit. Every single one of these alternatives, sertraline or Zoloft, venlafaxine or Effexor, prazosin or Minipress, trazodone or Deserol, hydroxyzine or Vistarol, Buspirone or Buspar, they are fundamentally different from benzodiazepines because they support, rather than suppress, the brain's ability to heal and engage in psychotherapy.
Absolutely.
Now, before we wrap up, we need to dedicate a specific moment to a population where this issue is overwhelmingly prevalent. We have to talk about veteran-specific considerations.
The veteran population carries a uniquely heavy burden regarding this specific pharmacological trap. Historically, the rates of benzodiazepine exposure in the VA system were astronomically high. We had entire generations of combat veterans returning from Vietnam and later from Iraq and Afghanistan with profound, complex trauma who were essentially chemically restrained with long-term clonazepam or Klonopin or diazepam or Valium prescriptions because we didn't have better tools at the time.
And the nuances of combat-related PTSD make untangling this even more incredibly complex. You aren't just dealing with fear, you are dealing with profound moral injury, severe survivor's guilt, and incredibly high rates of comorbid substance use disorders, which often started as desperate self-medication for physical pain from injuries or psychological trauma.
Exactly. The addiction risk in this population is a massive multiplier. This is precisely why the VA healthcare system has actually been at the absolute forefront of the national deprescribing movement. They recognized the harm and pivoted. They pioneered much of the clinical research showing the success of alternative treatments like prazosin or Minipress for combat nightmares. But for a clinician out in the community working with a veteran who has been on a benzodiazepine for 20 years, you must understand the vital importance of a highly structured, heavily supported tapering plan. You cannot just cut off a veteran's medication and send them on their way. It requires a robust, multidisciplinary approach. You often need to integrate psychology, social work, addiction specialists, and peer support groups alongside the slow pharmacological taper.
It takes a village to undo decades of chemical dependence and untreated trauma. All right, we are rounding the corner to the end of our masterclass today. Let's consolidate everything we've learned. I want to do a rapid-fire summary of the absolute biggest common clinical mistakes, the pitfalls that you, the listener, need to actively avoid when treating PTSD. First up.
Mistake number 1. Continuing benzodiazepines long-term without an exit strategy. If you inherit a new patient who is already on lorazepam or Ativan, do not just lazily rubber stamp the refill to get them out of the office. You must initiate a compassionate but firm conversation about the long-term plan and the need to eventually taper.
Mistake number 2, using them as the primary PTSD treatment. If you're prescribing alprazolam or Xanax without simultaneously initiating a first-line SSRI like sertraline or Zoloft, or without referring the patient for evidence-based trauma therapy like CPT, you are not treating the disorder. You are just masking the symptoms. Benzodiazepines, if used at all, and the highest guidelines strongly suggest they shouldn't be, should only ever be a microscopic, highly temporary bridge.
Mistake number 3. Failing to address physiological dependence early. If a patient is starting to call the clinic a few days early for their clonazepam or Klonopin refills, or if they admit to escalating their dose because it's not working anymore, you must address the tolerance and dependence immediately. Do not let it slide. It will only get worse.
And finally, mistake number 4, which we cannot stress enough, abrupt discontinuation. Never, ever abruptly stop a benzodiazepine, especially short-acting ones like alprazolam or Xanax, due to the life-threatening risk of severe withdrawal, rebound panic, and seizures. Always, always taper slowly, using the principles we discussed, like cross-tapering to a longer-acting agent such as diazepam or Valium to smooth out the physiological drop.
Avoiding those four mistakes defines the difference between a clinician who is inadvertently causing long-term harm to their patient and one who is actively facilitating true recovery.
Which brings us to our wrap-up. If you take only one thing away from this entire deep dive today, let it be this core realization. Benzodiazepines provide an incredibly seductive, highly convincing illusion of short-term relief. But at the fundamental neurobiological level, they are actively impairing the traumatized brain's ability to achieve long-term recovery. They block the critical fear extinction pathways, they induce profound emotional blunting that completely sabotages evidence-based trauma therapy, and they psychologically reinforce the very loop of avoidance that keeps PTSD alive.
You have to constantly remind yourself what is happening at the GABA receptor. When you prescribe these drugs, you are prioritizing short-term sedation at the absolute cost of long-term synaptic neuroplasticity. You are chemically freezing the trauma in place. So I will leave you with this final provocative thought to mull over before your next clinic day. Next time you reach for the prescription pad to silence a patient's profound distress, take a breath and ask yourself, are you actually treating the trauma, or are you just muting the fire alarm system while the house burns down?
Let that sit with you. It changes the way you look at a prescription pad. And once you've digested today's masterclass on what not to do, we want you to join us next time for the logical conclusion of this journey. Our next deep dive will be putting it all together, the full PTSD medication strategy. We'll be walking you through exactly how to build a complete, sophisticated, and evidence-based pharmacological regimen from the ground up, utilizing all the alternatives we touched on today. You won't want to miss it. Keep learning, keep questioning your assumptions, and we'll see you on the next deep dive.